Okay, welcome everybody. Welcome back to CPD. We are very pleased to have our speaker today, Dr. Sarkis Nalbandian, who's a specialist prosthodontist in Sydney. He's a good friend and colleague of mine, and we share a lot of multidisciplinary cases. He does wonderful cosmetic dentistry, very good on implants. But today I've asked him to speak specifically on treatment of orofacial pain. Now, a bit of background on Sarkis. He did his he did his dental training in Sydney, where he got honours, and he then did an MClim Dent in Prosthodontics, King's College, University of London, which he's still on faculty. He then came back to Australia and did his D-Clin Dent at Sydney University. So a wealth of experience. He's a funny guy to listen to talk. He's always got good jokes. I hope you're going to put some jokes in there, because you've got to have some jokes when it comes to orofacial pain and splints.
Oh, right? Absolutely.
But what I've asked Sarkis to speak about tonight is really, how does he think when a patient comes into him with orofacial pain, bruxing, etc., goes through the thought process, who needs a splint, who doesn't, if they need a splint, what type of splint do they need? So, Sarkis, you can start in a moment, but I'll just let everyone know, if you come in late on this lecture and you like it, please share it with your friends. It stays on my Facebook feed, Derek Mahoney 1, 2, 3, and 4 for the next 4 days, and then we ship it over to our free education website, which is called eodo.teachable.com, and there you can send a link, watch it again, answer CPD questions so that you can get your certificate. Now, Sarkis, you start talking. While you're talking, I'm going to open up my live feeds on the other Facebooks. And probably in about 2 minutes, you'll have the full audience. Doctors, during the lecture, please post your questions in the comment section, and then at the end of the lecture, I'll come back on and read the questions for Sarkis for him to answer. Is that okay, Sarkis?
Absolutely, absolutely.
Okay, thanks again, Sarkis. I'm going to mute myself and stop my video, and it's over to you. Thanks again.
Thank you, Derek. Thank you. Well, thank you, Derek, for your kind introduction. I think TMD and orofacial pain is a very important part in prosthodontics. I mean, we see a lot of patients in pain, and somehow one of the reasons that I decided to talk about this is, and we discussed with Derek initially, is what is the thought process that I go through based on my experience and my training in terms of diagnosing and assessing the orofacial pain patients, especially in prosthodontics, because in many ways, we all feel that when a patient comes in, you have to place an occlusal splint or do some sort of restorative measure, such as increase the occlusal vertical dimension to be able to treat these patients. The fact of the matter is nothing short of truth. I mean, those procedures for a lot of these patients simply are not the first modality of care. To proceed further in this lecture, I did a little bit of research in the Facebook channel, and there's a TMD discussion group. I'm sure a lot of you who have this discussion TMD on the Facebook can see this famous picture. And you can see that whenever we talk about TMD, everybody focuses on the ligament, the condyle, the muscle, the disc, the fossa. And somehow we as dental practitioners educating the public that TMD is to do with the joints or the muscles. Well, there's some relations, of course, but that's not always so. I've gone in and to have a look at some of the cases that patients actually do write in the Facebook column on this discussion. And this is from Keith Godfrey. You can actually have a look at yourselves, dial in terms of later on the Facebook. This is done a month ago, because I've been preparing for this lecture for some time now. And the patient says, I'm writing here and sitting here with tears. I just don't know how to end all this pain and suffering. Since April last year, I had a severe illness. I've been, every damn year into the country and tried everything I can think, but I'm still in agony. It never, ever goes away. It feels like I have a permanent ear infection, fullness of both ears. Radiation done in my jawline. Top off for 6 months, I had pain, pressure in my right eye, along with a facial numbness. I feel like my eye is going to explode. Okay, and you've guessed it. It never, ever goes away. No painkillers help, nothing else. My life is miserable. I'm at my ends with my teeth. So I'm waiting for tubes to put in my ears, and so many specialists who can't see anything wrong. I just have no idea what to do. Try physio, splints, vitamins, balloon compression kits, and the rest of the stuff, everything else under the sun. So please help. Now you can see some of these patients are suffering, and they're suffering for a number of reasons. And I'll come with time to explain why these people are going through this process and why we help professionals, especially in dentistry, to diagnose these cases. This one, tomatorosins. I'm so frustrated with this TMJ pain. I try everything from splint to dental treatments, anything else I do. How can I get this bite balanced? So obviously here, patients has about 7 splints, and the dentists are basically focusing on the bite. And naturally, if you're a dental practitioner and watching this webinar now, you probably think that my splint is better. Well, think about that. I will illustrate this during the course of this lecture. Let's move to the next patient. And this one, as I remember exactly, at that point in time, very well-known expert in the world, Daniel Manfredini, comes into the Facebook and says, you probably received the wrong diagnosis. Working on dental occlusion or trying to recapture the disc is not a standard of care practice. I hope you can find a certified orofacial pain expert. Now, this is a statement that I think we need to really understand. For some reason, dentists think the orofacial pain, TMD, have a lot to do with the bite. Well, I will talk a little bit more as we go on. I just want to talk about the patient, not about the dentist. What it was told, the patient, you need to see an orofacial pain specialist, okay? To put bluntly, another splint or orthodontic is not likely to help you where you are, the once in a location of the patient. And it talks about the other orofacial pain specialist, it talks about what he actually does for his patients, And we go into the next one, and it says, I'm sorry it upsets or it triggers anyone, but I just can't live with this anymore. So the patient is suffering in pain. They have ear pain, jaw pain, cracking, pressure in ears, pops, jaw spasm. They have a problem with hearing. It's just 24/7, and patient is in desperation asking for help. Okay, now doesn't know how to cope with this pain. Okay, and the most important is he has so much anxiety, and all because his temperamental joint is doing to him. He just needs some reassurance, some positive stories, or anything that give him some hope. Now, this is an interesting point. People need hope. People need guidance. Your patients need guidance. And moving on again, Natalie starts to draw on actual neck. There's so much pain raised down for my entire arm. A lot of painkillers, nothing helps. My neck's tight. She knows all the trigger points, etc., but I can't bear this anymore. It's interesting. The most important thing that we understand is that, again, dentist comes up, talks about the occlusion and orthodontic. And thank God at this point of the conversation, Daniel Manfredini comes in and says, orthodontics should never be used. This is a world expert on TMD management. Dental occlusion is not the problem for TMJ. With orthodontics, you could feel better, but you improve also with less invasive methods. That's a paradox of TMD practice. And again, the patient response, dentists are milking money on sufferers' pain and cover up their ignorance with arrogance, when in fact, they have no clue. They are really annoying. Exactly how I feel. No one really knows what they are doing, but charging like they do. This is interesting because it doesn't make sense to me. And this is not something that we expect our patients to feel. Having said this, patient presents with pain. And how come it still hurts if there's nothing wrong? This patient's face tells you that they're in pain. They're in a lot of pain. Which side is it? Is it the left side or the right side? You can see the changes in upper lip contour. She feels a lot of pain. There's some sort of numbness associated with the right side. I can already tell there's something happening on the right side, but patient, I can't tell until I interview the patient. And in many ways, pain is invisible. It's invisible, and patient will describe you in their own words exactly where they feel pain. What we need to do when we do the diagnosis is understand, taking history, examination, doing special tests, but most importantly, being empathetic to the patient's needs. This is not about putting the patient on the chair, opening their mouth and watching around. You have to really change the way you approach these patients. So the question is, do you really want to treat patients with TMD and facial pain? It's a really chess game. And so some of the chess game, you start thinking. You need to think very hard, very thorough, because people are coming in your surgeries with pain that if all you have to offer is an occlusal splint, I'm afraid you're on the wrong platform. So you're the doctor. Start thinking. Orofacial pain and TMD are thinking doctor's game and not some type of mechanical quasi-solutions. I made this statement, it's a very strong statement, and I will qualify it during the course of this lecture. The biologic value of pain is that usually pain signals a tissue damage. However, pain doesn't always occur after injury. And when it does, the intensity of pain we feel is not always proportional to the extent of tissue damage. Pain doesn't always occur after injury. It's also influenced by the past history, cultural values, and emotional state of mind. When we think that pain is a perceptual experience, the quality and intensity of which is influenced by unique past history of the individual to the pain-producing situation. Patient's emotional state at the time is extremely important. This has happened usually during the war, when people had their legs chopped off from the war torn situation with shell injuries, etc. Everyone's on the same platform, so obviously the pain doesn't hit you until you realize afterwards. Pain can be seen to be a function of the whole individual. You cannot separate this from the individual. You're seeing the whole individual who is actually experiencing pain. So when we look at the paradigm that we need to look at this, and in many ways, as we think the need for a new medical model, a challenge for biomedicine, Engel in 1977 discussed the whole individual. He created a model of biopsychosocial model. And this is very important as it's a comprehensive approach to biological, psychological, social, and pathological overlap, hence a modern approach to examination. Dworkin and Laresh in 1992 placed this model into dentistry in the management diagnosis of TMD. So we're looking at biopsychosocial model. And this presents a concept where it validates the patients with TMD should be assessed according to the biopsychosocial model, looking at the physical disorder and the psychological illness that impacts factors. For instance, is to provide an inclusive approach to the management of TMD. You have the physical symptoms, and you have the patient with the whole concept that surrounds this patient, their emotional position, their emotional being, their social being, that is so important in how they react to the pain and how they manage the pain. Initially, when they measured this, and what they proposed was the fact that pain has two components. The physical condition, they call it axis 1, and psychosocial condition, they call it axis 2. Now, this is a complex approach. I can't explain this in the next 45 minutes of lecture. But it's very important to understand that looking at the whole individual, the biopsychosocial clinician, and looking at a comprehensive way, you get biological, psychological, social, and all the pathological overlap that allows you to have an approach to the examination of your patient who presents with TMD. So diagnostic criteria for temperamental disorders that's validated, and later on in 2014, it became diagnostic criteria TMD rather than research diagnostic criteria TMD, because we're able to use this in clinical situation. Well, when we look at facial pain diagnosis, the important part of this is history and interview for the pain patients. History is a critical part of the diagnosis of facial pain. The clinical examination, the diagnostic test you perform, and self-report. Look at head and neck, cranial nerve examinations. You need to also rule out the odontogenic problems like gum, so tissue injuries, trauma, periodontal problem, decay, dental lapses, etc. So it's important to understand And we're looking at as a TMD, as an overall concept and facial pain. It's not just one to do with dentistry. It's a whole area of it. If you see on the top of this axis, this is a Bell's oral and facial pain 7th edition by Okerson. And we classified orofacial pains. You can see the axis to psychological conditions. There's anxiety disorders, there's meal disorders. And all this is combined with a physical condition, which is axis 1. And the TMD is a deep pain, it's a somatic pain. Deep pain comes musculoskeletal pain, looking at blue, periodontal connect tissues, find the TMJ, muscle pains on the bottom there. Eventually it comes on to the actual ligamentous pain, retrodiscal pain, capsular pain, arthritic pain, all the areas that we are concentrating. But however, it's an overall scheme. You have to look at the patient as a whole. And looking towards upper right, where the axis 1 and 2 that allows you to achieve diagnosis. And you have to look at the whole patient, not just one point, which is the temporomandibulal joint or other structures such as muscles. I will later on look at the occlusion if it's really necessary. Now, TMD diagnosis, most common orofacial pain, dental pain, pulpal, and periodontal. By definition, TMD is a collective term embracing several clinical problems that involve one or combination of masticatory and neuromuscular, the temporomandibular joint, and associated structures. It's muscular because it's related to muscles of mastication, and skeletal articular as a disorders related to the temporomandibular joint. Diagnosis is based through thorough history taking and physical examination. The gold standard for diagnosis of TMD. You palpate the muscles after you've taken a thorough history, and we're talking about the physical examination because the history is number 1 in here. Temporomandibular joints, you measure the range of movements, and naturally, if you need, you can look at radiographic findings. I don't always do radiographic findings because basically clinical examination history will give you a lot of clues, and I will only go and test my initial diagnosis if I need to by using radiographic findings. This could be a simple OPG, or cone beam CT, and rarely MRI if it's really required that I have a problem in finding whether it's a disc displacement or etc. We'll talk about that maybe not in this lecture, but some other lectures in the future. So in many ways, assessment techniques, we need to be a good listener. Listen and learn and assess. By this, when a patient presents in your practice in pain, you gain the patient's trust. That patient has been to many other dentists and other medical and practitioners before. So they basically don't want to sit down and basically talk to you unless you're prepared to listen to them. They're frustrated. And in many ways, you can't see those patients during a very busy session where you're doing a lot of production, when you're doing major kind of bridge work or other issues. You have to have a specific day where you see these patients, and best to see them in the morning, and they're less tired because pain tires you. You stop and ask him, tell me about your pain. What makes your pain ache or better or worse? Do you wake up in the morning or with symptoms? The most important thing is not to interrupt. I see this often and often where practitioners interrupt in over 65% of the cases. Let the patient talk and listen. Patients are already giving you a diagnosis. By listening to the patient, what they're telling you, you're almost going to pick up 70-75% of the diagnosis by simply listening to them before you have started the examination. This is critical. It's an art, but it can be learned and we teach this in our college as well. Now, AADR, the American Academy of Dental Research, TMD policy statement, and in 2010, put out a very important statement. Enlightened, the treatment of TMD should be conservative, management, not treatment. It should be reversible, management of TMD, and musculoskeletal pain of jaw muscle system. The natural cyclic evolutional condition, also referred to as regression towards the mean. What does it really mean? Regression means the pain gets better with time. It fluctuates, but comes to the point where it's the average of all the up and down cycles of pain. It's very important. So the professional treatment should be augmented when you explain to patients how you're going to treat these patients or manage the patient with a home program in which the patients are taught about the disorder and how to manage their symptoms. the aim of the management of temperamental dysfunction to make the patient become their own doctor so they know how to manage this condition, because we don't really have a perfect treatment yet. It might take years to come. And the most important thing that I was at last year at the Cologne, I think last year Cologne, where we're walking down to the aisles of huge amount of dental industry and all the inventions that are presented. For some reason, there is an article that is being sold that there's all these jaw monitoring devices that tells you how to treat TMDs and and that aids you the diagnosis of temporomandibular joints, such as pressure, algorithmic muscle tenderness, or surface imaging monitoring, jaw closures, jaw tracking, and sound vibratory analysis of joint sounds and movement. And one of the reasons that Baba did review, and many other authors have done reviews, there's probably about 20 or 30 reviews on this subject. I just chose Baba just as an example. The results from these instruments shows that most of the data that's coming from this instrumentation is overlapping. It's got high variability. It's got low sensitivity and the specificity, and unknown interpretations of reading. In other words, we're being extremely vague for this system. So the gold standard for diagnosis of TMD, and when using electronic auxiliary instrumentations, they do not aid in the diagnosis of TMD, and full stop. The gold standard for diagnosis of TMD is a global clinical examination and a thorough history taken by an expert examiner. And once you master this, you can become an expert too, as you learn how to listen and diagnose and take good history and make a good physical examination of your patients who present with facial pain. The etiology of temporomandibular joint is multifactorial, and the progress is still unknown, with no clear determinable factors to identify patients at risk. Although there are some areas that help you to identify those patients at risk with the recent opera studies, but signs and symptoms are found in patient TMD from childhood to late in life. The joint sounds do not always predict or diagnose the presence or absence of disease. But generally, females as a gender seem to be more attuned to report TMD than males, especially in early adulthood. When we look at the biopsychosocial model of the disease applied to temporomandibular joint disorders, we look at patient A and patient B. And in many ways, the patient A in this situation has a mechanical temporomandibular joint disorder. In other words, without secondary psychosocial factors. In other words, you have a click or a pain or myalgia, may have intense pain, but there's not stress or not distress, and has no pain-related disability. So these patients are very easy to treat in the sense they don't require a major multimodal treatment and management, but mostly they require just a simple, minimal conservative treatment that will reduce their pain and into manageable levels. But when you have a patient with severe myalgia, that's muscle pain, where the joints are not involved, and even the slightest moderate pain, and with the state that they're in, they have anxiety, they have depression, and they're simply disabled by pain. And also there's a underlying parafunction that's present, their pain's amplified. And this is where the management becomes difficult. This is where you need other colleagues in the area of facial pain management to help you to manage the patient and reduce the pain score of this patient to manageable levels. So OPERA study is a major study. I suggest you look it up. They talked about predictors of temporomandibular dysfunction. There's a presence of significant predictors from baseline clinical examination where pain on jaw opening, painful palpation, masticated neck and body muscles, and general body pain 6.4 times more likely to happen in patients who have headaches. Again, looking at the how does a pain in many ways influence, looking at subclinical signs and symptoms, looking at psychological distress and pain amplification that contribute to the onset and persistence of TMD. This is a model by Meixner, and basically this model predicts the following: that patients with higher psychological stress, which is basically governed by the mood, anxiety, depression, stress response, and somatization, is also able to go to the high state of pain amplification, and they're related to each other. And that depends upon the patient's health system. And if there's a dysregulation of the nervous system, and you need to diagnose this with your medical colleagues as well, they will help you in helping this patient to manage oral pain. You're going from subclinical signs and symptoms to transient TMD, then you're going persistent TMD. And here, time is extremely important because different individuals respond to trauma, whether it's a physical trauma or psychological trauma, at different levels. And it's very important to understand that it's simply very hard to predict which patients will go to which level of pain dysfunction and what their level of ability and coping mechanisms are. Furthermore, looking at predictors of TMD, pain amplification as determinant of the TMD onset and persistence. We understand that low of these patients, there's an alteration in peripheral and central nervous system, with the net effect is amplifying the perception to painful stimuli. Pain amplification is hyperalgesia, allodynia, and central sensitization. Allodynia is a raised threshold. In other words, a normal touch sensation that is actually doesn't elicit pain, will elicit pain on these individuals. And hyperalgesia is when you have an extraordinary painful response to normal noxious stimuli. And central sensitization can occur immediately or usually starts with peripheral sensitization and then travels along the nerve highways to the cerebral cortex. Now, mechanisms contributing to this pain amplification can include decreased function in inhibitory system that the patient has, or enhancement of the pain facilitator pathway. So pain amplification is a heightened responsiveness to the degree of sensory testing as well as spontaneous clinical pain from deep tissues, such as muscles, joints, and visceral organs. So looking at the axis 2 of predictors of TMD, surgical stress varies with time and stress, all to do with genetic background of the individual, influenced by genetic susceptibility, genetic polymorphism, comp genotype, we'll talk a little bit of this later on, and variations makes more pain, increase the incidence of TMD. Naturally, time is an important factor. The genotype, comp genotype, it's very complex, but one is to understand that usually in females are more affected by this genotype, and hence they have more response, more exaggerated response to pain, because it affects the opioid neurotransmitter response to pain stressors. What it means that the enzyme that metabolizes the neurotransmitters is low, and so that increased amount of neurotransmitters are present in the synaptic connections. And that increases, amplifies the effect of stress, and hence the risk for temporomandibular pain. Or parafunction and TMD derangements. Well, patients knows the best. And it's from the OPERA studies they can see, and it's been didactic, that self-reported temporomandibular joint noises remain a significant predictor of TMD incidence. So when a patient comes and says, I feel my joints as clicking and noisy, it's annoying me, etc. I mean, a lot of joints click, and my joints click too, but it doesn't bother me. But if the patient really is obsessed about this, there's more chances of happening. Your role as a dentist is to be able to reassure the patient this clicking is normal. He needs to reduce, and I'll describe later on how to reduce any trauma to those joints to allow it to rest and keep the teeth apart, soft diet, etc. Very important part of the management for these patients. So the risk of TMD is elevated in participants who report a high density of parafunction behavior, that is loading the masticatory system. So looking at 10-year research prospective study, looking at OPERA studies, preventing TMD, we realize that TMD develops at a disproportionately high rate in people with relatively poor health, very informal comorbid diseases or other pain conditions, especially poor sleep quality. I think Derek talks a lot about this. Poor sleep, sleep apnea, etc., cigarette smoking. The effort to promote good general health should therefore be supported as a method of primary prevention of temporomandibular dysfunction for these patients. When you talk about orofacial pain assessment, we understand that pain is an unpleasant sensory and emotional experience associated with actual potential tissue damage, described in terms of such damage. Therefore, both physical, that is axis 1 discussed, and psychosocial axis 2 status must be assessed using the dual axis model. I cannot assess patients' symptoms, complaint, without looking at axis 1 and axis 2. When the patient has the same pain score due to different contributing factors, the management will be different because they might have a high physical signs of pain, discomfort, but able to cope. That's a different management, like in the previous diagram. Or they have a very mild assessment, but you feel like, this is very simple, like simple clicking, but they're very uncomfortable about it. That's a different management. So you need to explain these patients and tune your treatments, not only to what you feel is physical in nature, but actually understand them, help them, and support them psychosocially with these patients in order for your treatment to be successful. This is why you need other people in the team. So not only baseline score medical and legal reasons, but also orofacial pain may signal life-threatening conditions like I showed you initial Bell's facial pain diagram, such as intracranial disorders, when the pain increases in severity, abrupt onset of pain, pain that interrupts sleep, pain precipitated by exertion or positional change, neurological deficits. So all these are really, really important to understand, that you need to think globally and not just locally, focusing on temporomandibular joint and associated masticating muscles for your examination. Acute and chronic pain. Acute pain is duration where the underlying cause is obvious. If you hurt yourself, you cut yourself, there's acute pain. Chronic pain is a long duration. Again, time is a variable factor for different individuals, and it varies. Sternbach considered that more than 6 months is an essential difference factor. However, today we feel even 2 weeks more is considered as a chronic pain. So distinct from acute pain. There are patients that utilizing with the chronic pain of low of the healthcare services. It actually chokes the healthcare services of chronic pain sufferers, and then sometimes becomes a dependency where they have a lifestyle characteristics and conflict, and this person's quality of life is changed, and they no longer feel they're part of the society. So it is important to understand how you treat those patients and the empathy that portray when you're examining and managing these patients is a crucial part of your inventory as a clinician. General assessment guidelines. When I'll examine the patient, is the pain site the same as pain at source? Is it local origin? Or is it referred from nearby structures? Or the source is a distinct structure or organ system? Determine a etiology or mechanism, assess the pain disability behavior and how it's relating to the psychosocial status. Taking pain history, understand the pain assessment is subjective experience and depends on different patients, how they describe their own pain. However, you cannot measure pain objectively, and it's always reference point is each patient has their own pain reference point. The presenting complaint, present illness, past medical history, current medications, review of system family history, social and occupational history. Now I have a family of mother and son, both have fibromyalgia. And after mother, son developed fibromyalgia from the age of 18. And they both have similar situations where they cannot work for a number of months. They only attend for the dental treatment if they're in a better state of mind. And we have to be able to treat those patients in a very careful manner, not to trigger the pain dysfunction. When you look at the characteristics, again, it's quite a lengthy statement, okay? We look at number of parents, but the spread of pain, location, the extent referred. Look at McGill's pain descriptors. We get the patient to draw a diagram. There's a number of we'll be discussing in the lecture with Derek, I think in about a couple of weeks' time. And we have to understand that what sort of treatments patients had and effects, any symptoms, any altered sensations, any swellings, any occupational contributions, the functional activities, functional impairments. How does it affect the patient's quality of life? When the patient has their facial expressions, have they talk, their verbal reports, functional limitations, disability due to pain? Is it affecting? how they speak, their speech, all the psychological aspects. You have to look at the whole being, the biopsychosocial being of the patient, the impairment. You look at physical examination, all the areas of head and neck that you need to examine, the range of movement, soft tissues, lymphadenopathy, temporomandibular joints, cervical muscle, cranial nerve examination. Inspect all the areas that have been taught in undergraduate school or in other postgraduate courses that helps you to understand. Teeth and periodontium, including occlusion, is also a check. Why do I check occlusion in this situation? Because I haven't spoken about occlusion and TMD for a while now. And one of the reasons is if a patient presents with arthralgia, for instance, if there's swelling of the one of the joints, there will be ipsilateral posterior open bite. Or if, for instance, they have an acute disc, anterior disc displacement without reduction, there will be more pressure on the teeth on the ipsilateral side. But on the other hand, if the patient has got rheumatoid arthritis or degenerative joint disease, they will develop an anterior open bite with time. So occlusion in that case gives me a lot of clues exactly what's happening. How do we measure pain? We have through visual analog scale. That's independent of that's dependent on this patient. We look at McGill's questionnaire. We look at to draw a diagram, the pain disability. Okay, usually if patient says my pain is more than 5, okay, then obviously this pain disability has changed the social activities and work. And we also take caution if the patient's been away from their usual activities more than 15 days in the past 6 months or over the years. One important part is psychological status assessment. If the patient has higher somatization and they're preoccupied of non-specific physical symptoms and depression, anxiety, is a trifecta of chronic pain sufferers. So that should be able to alert you of your treatment that you're going to approach with the patient. Again, you can't just place a splint in this patient's mouth and assume that's going to make the patient better. Confusion is that when the pain and the hurt is present for a short time, it's interpreted differently from when it's present for a longer time. It's not a question of there not being a problem. It's a question of how we deal with it. The longer you have the particular pain problem, the more complex is the management. If the problem is long-lasting, it might require stress management or relaxation therapy or counseling. We need team members to dampen the sensitized nervous system from a psychosocial point of view, while we're helping the patient to cope with home care and cope with his or her pain management. So at what point does acute become chronic? Usually, if the patient says that pain is more than 5 out of 10, there's a good chance this patient can become chronic. We treat all patients, therefore, in my practice, as a chronic pain. I look at the patient in total context. 2 weeks, chronic pain, and not 6 months. One of the important things for the patients with anxiety, depression, catastrophizing is that patient presentation to different health professionals will give you an idea where I've been. Recently, I had a long-time standing patient of mine. He's about 25 years of age. A mother was in dire straits. Basically, said, my son in pain. He's a neurologist. He's a neurosurgeon. He has seen everyone else, and they think there's nothing wrong with him. Can you explain what's the problem with my son? And well, I said, who referred you to me? He says the ENT surgeon referred to me saying it's not the ENT. I can see some areas of cystic formation maxillary sinus, but that is not going to help his pain. Go and see your dentist. And when the patient presented, we examined the patient, both the Axis 1 and Axis 2. I realized that patient has seen already other medical specialists. I made a phone call to all the different specialists, introduced myself, and I asked him if I can carry out pain to be a simple treatment to break the pain cycle. So we applied a local anesthetic to the muscles that was hurting, especially the mass of the muscle on the side that was hurting, gave the patient instructions, and patient returned after 2 weeks, and with the home care, several shall describe later on, reduced the pain from actually VAS 8 to about VAS 2, a manageable situation. And we taught the patient how to manage his own pain. So you need team, you need the dentist, general practitioner, oral medicine, maxillofacial surgeon, prosthodontist, endodontist, periodontist. We have physiotherapists, psychologists, pain specialists, okay, and access to, if the patient is severely depressed, highly somatized, maybe they can look at the antidepressant therapy, but while a psychologist can look at cognitive behavioral therapy, and natural pain specialists can look at other modalities of controlling the patient's pain. Because once the patient has central sensitization, it gets more difficult, more problematic to be able to help this patient to reduce the pain symptoms and related physical disabilities. So risk factors for TMD, females generally have free ratio of 3 to 1. And realized why is because of their genetic predisposition, there's trauma, severe clenching or bruxing, loading the system. Third mole removal with severe opening can traumatize those muscle tissues, and also high level of somatization. It's preoccupied with non-specific physical symptoms such as depression, anxiety. Okay, the trifecta for chronic pain sufferers. And we look at the predictors of chronic pain in a nutshell. If patient presents with very severe high level myalgia, there's a good chance that they will proceed to chronic pain. So Epgard, back in 1999, the findings was that 200 acute TMD patients did all the relevant diagnostic criteria tests, and the groups did not differ in their scores of biopsychosocial area. And in terms of looking at all the two variables, they made accurate prediction about 91% among the patients who went to develop chronic TMD within a 6 month period. So it's very important to assess those patients who have a higher pain intensity. They are important to be able to reduce that pain to manageable levels to prevent the acute pain becoming chronic. So what do I do for all these patients? I try to break the pain cycles by finding what the source is, and you need to retest sometimes, not a simple quick assessment of the sources, and understand we do a lot of Access 1. There's quite a number of pages you have to fill up for Access 1 and measure them, which I cannot talk at this stage in the lecture because it's only a short time. And then we look at Access 2, but we explain the patient nature of the condition after they completely understand. I also carry out video recordings where I discuss with the patient, but initially the patient tells me how they feel, the pain status, how it's affecting their everyday quality of life, their work, any disability that's related to pain. And we normally like to give them anti-inflammatory cream, such as Voltaren gel or 25 milligram tablets. And it's important to understand that you have to assess the patient allergic to this or any gastrointestinal or any hypertensive disorders. But usually to allow the patient to have immediate improvement, I like to place small volume of local anesthetic and superficial muscles, provides rapid and sustained relief of pain, and it's important in my practice to break this pain cycle. I do not use Botox for these sort of situations. Most of the time you can use a simple local anesthetic in the saline to be able to do this. So the Botox is not the area that I'll be using in this particular situation of patient presenting with acute pain. So occlusal splints. I'm sure you've been waiting to hear about occlusal splints. I'm sure everyone said, what's happening with the splints? Now, how do I make a splint? It's often, I remember talking to Derek once, and he said, Sarkis, can you help this dentist? And the dentist was explaining that he just about got this occlusion right. He just wants to modify the splint, put the jaw just a little bit more forward to capture that. This is almost there. Once he gets another millimeter forward, the occlusal splint, we got it. Well, I'm sorry to tell you, it just doesn't work that way. My advice to the dentist was, can you get that splint in the patient's mouth? I said, can you open the window of your practice and just throw the splint out? I said, it's got nothing to do with the management of your patients. And I'll tell you when it's important. When important is that when you think the patient is not doing home compliance and you feel that we need to change a habit of the patient who's got loading masticator system, if you describe the splint in a way like it's more of a placebo effect, well, look, you know what? Those things didn't work. Obviously, you're assuming that they didn't do the home compliance. You can't reduce the pain, and they're clenching hard. You feel the grinding and wear facets in the teeth, and they're loading masticator system. You probably want to say, okay, you know what? Maybe you should give the splint. That may be benefit. But in the meantime, explaining and creating placebo effect to say, with this splint, I believe, will help your situation, since the other treatments didn't quite work. We're going to try this out. However, you do not give the splint as the end point of the treatment. It's only to help the patient reduce trauma to the system. So here's our patient. This is Carla. And the funny thing about this is Carla has probably about 20 splints. I haven't got the whole pictures. And I remember when I saw Carla 15 years ago, and she's an ex-model, now is in real estate. And Carla said to me, you know, Sarkis, I would have spent more than $10,000 for the splits. And none of them work. So when dentists tell me that my splint is better, I can make my splint work better, because I'm going to put that jaw in the right position to reduce this patient temporomandibular dysfunction. It just concerns me because we are then converting these patients to be dependent on the type of splint. Or if you're adjusting your occlusion for this patient, and if the pain suddenly goes away, discomfort goes away, it's only placebo effect, it's going to come back. So you basically sensitize this patient to be dependent, thinking that her discomfort, her pain, his or her pain, is dependent on the splint or on the bite or other forms. Therefore, you are sensitizing the patient to the wrong direction, because your diagnosis is wrong, your diagnosis is incorrect, and the patient will suffer subsequently. This is the point I'm trying to make. Before you try to make the patient think that, oh yes, we're going to make you push a splint, that'll take your pain away. Think about the symptoms. Think about the axis one, the physical symptoms, your physical diagnostics, your tests that you carried out. Think about the biopsychosocial position. Think how they're going to respond to you. And before you do anything else, you need to test the patient. Naturally, the patient is to gain your trust. You need to be empathetic before you chuck something in the patient's mouth and say, this is going to help the situation. I know you're probably right to say, you know what, I can open the occlusion of patient's pain away. I don't believe in that. It takes time, and we'll talk about it later. So, let me look at oral diagnosis. Orofacial region is unique as the pain is diffused. Why? Because of the peripheral and central sensitization. Toothache is not necessarily a toothache. You ask the patient if the pain is the same as the source. One of the problems we have is there's a convergence in the cranial nerve in that subnucleus caudalis that confuses the cortex. It's a complex area, and we have one Australian, Chris Peck and John Murray, who have written about this. There's some marvelous articles, and I'm happy to send these articles that the reader wishes to read. And the most important thing is that when the patient says, how come it still hurts if there's nothing wrong? Because it's important to understand. We need to understand how patients feel, where the pain's coming from. The more the pain is present, the more complex it is to treat the patient and reduce. So we want to reduce these patients to manageable levels. So persistent orofacial pain, and 61.3% had extraoral sides, chronic fatigue, irritable bowel, fibromyalgia. Therefore, when you're treating all of the facial region, it won't work. We need a multidisciplinary team with us to be able to manage the patient's condition. The process of diagnosis, it's important to tell the patient what's going on, what you're thinking. Take an hour. This is not a quick fix situation. You can't do this during busy time. Listen and ask questions. Intro, extra vitals, OPG, rule out what's obvious, periodontal and odontogenic pain. If not certain of diagnosis, please do not drill. Even if it's got a large restoration, if it gets close to the nerve, do pulp testing, do all the necessary regimens required for your diagnosis, because this could be neuropathic pain in origin. And management of the process, explain, reassure, and motivate. You know, if you need to take, you know, and it should be cognitive behavioral therapy. The aim is to be able to pain reduction, regain function, review, and future prevention. Better outcomes are obtained with early diagnosis and management. In a chronic pain, patients' 50% reduction success is a primary outcome. You need to give the patient skills to cope with the pain. You need a multidisciplinary team with you and pain specialists. You need to understand the biopsychosocial model and apply each and every patient to integrate the individual into the society. In terms of management, we need to manage acute pain so it does not become chronic. Muscle pain greater than 5 is a good chance of becoming chronic. If you imagine acute pain, and now 5 to 10, worst 10, if there's 10 out of 10, you need to contact patient's general practitioner. They need to get a mental care plan for 6 free cognitive behavioral therapy sessions. Okay, I'm usually in touch with patient's general practitioner or their psychologist or their neurologist, and I'm very much actively involved in trying to help this patient to be able to reduce their pain to manageable levels. Whatever is required, use medications, intervention, good diagnosis, patient education is a key to a good outcome. And good allergies and self-care and regular follow-up is an important part of the management of TMD and facial pain. Always consider non-invasive reversible therapy. Okay, why do we take Vasco every time they visit us? Because you're monitoring the pain. Patients are poor historians, and you're advising the patient. The consistently higher levels need to send the patient away feeling better when they come to you. Your interaction with the patient needs to be totally different from restorative component of prosthodontics. As a prosthodontist, when the patient has facial pain, it's a totally different patient than normal restorative care that's required. Got to be empathetic. Self-care similar to any musculoskeletal problems. Rest, self-care, ice on the joints, and moist heat on the muscles. Prosthodontic planning, a patient with temporomandibular disorders on bruxism. Manfred and Polgio did a systematic review. And at the moment, we don't have any randomized controlled studies on various topics concerning relationship TMD and bruxism and prosthodontics. And based on best available evidence, prosthetic changes in dental occlusion are not yet acceptable as strategies for solving TMD symptoms or helping an individual to stop the bruxism. Clinicians should take care when performing reversible occlusal changes in healthy individuals and in patients with TMD or bruxism. Well, when you're looking at treatment guidelines on patients with TMD, we need to look at a common sense approach. Care should be taken when performing dental procedures for patients with TMD because they can't open wide enough, but also symptoms may increase after procedures. Therefore, prior to procedure, you manage your TMD in a patient to comfort level, stabilize and reassess. Okay, home care, moist heat, reduce the chewing on the side, reduce wide opening, consider the non-steroid anti-inflammatory medication, consider relaxation, diazepam at night before the appointment, prefer morning appointments, short appointments over a long period of time. Most TMD patients are maladaptive to occlusal changes. You have to think about restoring before you start. Why? Did you miss the diagnosis of TMD? If the patient is in pain after dental treatment has a history of TMD, then once you start, unfortunately, beyond the problem. And this is quite common in patients because now they've increased sensitization, increased CNS sensitization. They re-trigger their old pain condition and the patient is in pain. So when it comes to patients who also present with neuropathic pain, which is a pain in the nervous system that's related to disease or trauma in the nervous system, basically, if let's say you're taking a tooth out, there's a nerve damage, or a patient comes out saying, look, I've still got a pain in this area. And after a long time, a few months, you feel, pain's not resolving. There's a good chance there's a neuropathic pain. And there's a way to treat those patients is to desensitize these patients. So we like to look at if it's a peripheral sensitization, the diagnosis is a capsaicin topical ointment, which is a very strong pepper. We try to block anesthetic, topical anesthetic. We try to reduce the pain that desensitizes the source of the pain into the nervous system. In a dental treatment, if you're doing a surgery for a patient with existing pain, you must have a profound anesthesia. A lot of the neuropathic pain is patients who have endodontic treatment where there's been a general trauma in the area, but that usually resolves. It's less than 3% that stays for a long time. So the patient's not managing their pain, try well, and you're about to start a procedure. It's much better to delay the procedure until your patient can be in a position of managing the patient well before you proceed. In the chronic pain, we regard chronic pain as a disease entity. In the World Health Organization, International Association of Study of Pain, They described the Global Day Against Pain in October 11, 2004, to promote pain relief as a human right. Evidence points towards chronic pain as being a neurological disorder on its own. It's a disease on its own right, chronic pain. So when these patients present in your practice, okay, you have to understand that it's important to diagnose, important to think, not to simply open the mouth, listen to your patient, engage them in a conversation. It's very important that they're actually talking to you, describing their symptoms, and they're helping you in your diagnosis. Based on your good history taking and your physical examination, you will be able then to help your patients and refer and have a multimodal team that will help your patients to reduce the facial pain and TMD to manageable levels. So take home message: you never treat a stranger. Diagnosis, initial assessment, test your diagnosis and reassess. Well, sometimes you have to accept humility. This case is beyond me, and refer. And I thank you.
Thank you, Sarkis. I'm just going to open up the Q's and A's. While I'm getting the questions, I've heard along the grapevine you'll put together an excellent comprehensive program in restorative dentistry, aesthetic dentistry, and implants. You want to tell the audience a little bit about that?
Thank you. Well, one important part was that I realized that as I'm talking to a lot of my colleagues, and what really initiated this is, we've spent this number of conversations ourselves as well, is that dentists graduate from dental school find it difficult to integrate more advanced dental procedures in their practices. And they really need a sort of mentor to help them. They don't want to do their courses, but unfortunately, that cannot help them to crystallize their knowledge. And the most important thing is that in terms of diagnosis and treatment planning, it's really an art and a science put together. And when a dentist graduates, if they have a good mentor, then the right path, then that's marvelous, but it doesn't always happen. So the new graduates having a mentor that will put them in the right path, help them in terms of understanding the evidence-based practice and evidence-based dentistry, and also having some sort of experience to point the right path, help them to choose the right cases, help them to manage some complex cases, initially starting with simple, naturally complex. So that really helps them. The other thing is that looking at aesthetics, sometimes when you think about aesthetics, people talk about digital manipulations. It's nothing like that. It actually can make you or break you. So ultimately, you are the clinician that's responsible for the patient care. You know, there's so many software, so many programs, and that's sort of behind the clinician, and clinicians taking a lot of responsibility in trying to take all this on board and then treat the patient. And yet, when some things do go wrong, no one's responsible for that case except the clinician. So in many ways, we need to accept the fact that the clinicians making good diagnosis, good treatment plan, understanding what happens when things go right and what happens when things go wrong, and also having a contingency plan so it's a fallback position in their treatment plan. Look at the whole thing, not just simply one thing at a time. I know it's always good to have procedures and talk about recipes. And if you're going to have a course that's based on recipes, then as a clinician, they need to think on their feet. They have to have an experience in thinking, making decisions. Not everything's a recipe. It's just empirical thinking.
So a couple of questions. Dr. Mock is asking, what are your thoughts on anterior 2x4 splits? I guess he's talking about NTIs and things like that. Is there an indication? If so, when and why?
Okay. The NTI splints, my concern with NTI splints is, you might recall, Derek, we have a few cases together with the NTI, similar to NTI splints, where there has been a change in inclusion.
Yeah.
And the problem is, again, comes to diagnosis. With NTI splints, when you issue this patient, I personally don't use NTI splints, but if you have to issue the patient, you have to have strict guidelines of reassessment. Now, the patient has to come in and make sure they come to your surgery every 2 weeks. So, okay, you can get them out of the pain immediately, but you have to reassess the patient. The trouble is, you can't control the other end. Because you control the other end, patient may walk with an NTI splint, come back to you after about 3 months, completely present with anterior open bite, then how are you going to treat this case? And mostly now they've developed the whole occlusal sense where they're not comfortable with it. And remember, they come with severe pain. I think one of the reasons for anterior spleen was that really severe acute muscular pain. And those people have a higher VAS score, and there's more chance that they are chronic patients. So, higher VAS score, more chance of pain becoming chronic. So suddenly you have actually made the patient feel that this spleen is actually doing the job, and it's actually not doing the job. So in this case, I would not use the anti-eye splints because I'm not sure if I can control the other end. I would rather give the patient a home care, explain the situation. It would be the first thing I will do as a occlusal splint. That's not the first treatment of choice. So the answer is, I don't think much of it.
And then I guess another question here, maybe along the same lines, but different. I hear a lot of people swear by Gelb splint. Can you please explain how this works? Now, Gelb, I guess, another word for a posterior coverage splint, so almost the opposite of an NTI. Sarkis?
I think, again, Gelb splint, you have posterior coverage, and there's more chance of getting posterior open bite there. You basically prolong use of these patients. You have an orthodontic movement, they have posterior open bite. And some certain institutions promote this type of orthodontic compliance so they can reduce the teeth, make a room, and basically some crowns build them up. The problem with this, again, you are treating a patient's symptoms with an appliance, rather than understand their symptoms as where other conservative, non-invasive, reversible treatments do the same thing. So the pain fluctuates. It's like a sinus curve. It's a regression to the mean. Van Gogh talks about this. People have a different ability coping with pain. And for us to throw like a Gelb splint or an anti-eye splint in a patient's mouth, you're actually transposing this patient to be dependent on your appliance. So I have patients actually come with Gelb splint who just cannot even talk or eat without the splint because now the teeth positions change and they're used to the same vertical dimension which they normally are with the Gelb splint.
Yeah.
So then becomes a bar. Then becomes what do you call twin block appliance. So you have to cut them up and allow the posteriors to erupt to regain the occlusion. It's funny. You create a problem, you have to reduce it slowly to go back to normality.
Yeah, perfect. And then another question: how do you differentiate between a true bruxer versus a clencher, and are the terms the same? So that's a big question.
That's a huge question. I think Lobeso's got a very interesting classification of bruxism. I would say 1, 2, 3. It's initially clinical, you got history, and you got clinical, you got PSG as a diagnostic criteria. I guess, and PSG is the ultimate will tell you whether a patient is bruxer or not, when you're doing it. But for me, the differentiation between bruxer and clencher, true clencher, well, it's a hard one because if you look at a patient as a clencher, there's some oral signs, but it's very hard to differentiate because they could be clenching at one point in time. It could be like in a daytime clenches, or they'll be bruxing another time. So look at the wear facets. History is a good example for that for you. And looking at the other physical symptoms such as the tongue, the ridging, all the areas that, and look at all other manifestations, people clench your breath. So it's very hard to differentiate. I would say at this stage, clenches are more like a vertical bruxer. So irrespective, I call it parafunction, and that's what it is. It's just loading the system.
Yeah, great. So Sarkis, thanks very much. That's the end of the questions. I'm looking forward to the full curriculum. Did you give the doctors your link for the website for?
I'm just going. I'll just share my screen.
Yep. I'm sure there'll be a lot of interest.
Okay, if I can share my screen, I will show them the site.
Yep, okay. 1 second. I will. I'll just make you the host. 1 second.
Sure.
Try now, Sarkis.
1 second. Sorry about this. Okay, this basically is the website for the college on the right side, and you're most welcome. I think it'll be very exciting. I think time has come to bridge that important gap in dental education. And from a responsiveness so far, Derek has been excellent. And certainly I think it's important that we help our colleagues to achieve that confidence and gain to a knowledge of multiple mentors who are part of the faculty to help them learn and improve their knowledge and crystallize both their theoretical and practical skills in everyday dentistry.
Perfect. So, doctors, just to summarize, the lecture you've just heard, including the Q's and A's, will stay on the Facebook feed for the next 4 days. Feel free to like it and share it. Then after that, it goes to our dedicated free CPD learning format, which is called eodo.teachable.com. So, Sarkis, thanks again for a fantastic lecture. And we look forward to hearing more from you. And also, I think we've got I can't remember the dates for that now, but I think we have a orofacial pain 2-day course coming up.
We'll go through that time, a full scenario of how do we diagnose and assess pain, how do we manage our patients. And also, Derek, I'm very sorry, I couldn't tell my joke during TMD and orofacial pain. I'll have to do that next time.
What's that?
Thank you.
Good. In fact, I'm just trying to see if I can work out this format here. 1 second, Sarkis.
Sure.
I'll do it on the feed from before, just so I can end the meeting. Here we go. Yeah. So. My EODO staff said to let everyone know 15th and 16th of August 2020, 2-day course, treatment of orofacial pain, TMD and bruxism. We have Chris Kelly, who'll be talking about sleep bruxism, Stephen Tracy, who's been doing orofacial pain patients for many years, will talk about various splints. Sarkis will be doing a different talk to what he's given today. I'll be talking about differential diagnosis, also some case finishing for long-term splint patients. And we have Dr. Mariella Rosa, who did her research under Professor Ivan Kleinberg for 3 years at Sydney Uni. So a large number of speakers. And again, whole concept is, how do you manage these patients? And we all have these patients, and whether they're, I think more and more I see an intimate link between poor sleep patterns, parafunction, TMD, clenching, bruxism. I think you can't really differentiate them into nice little boxes. So hopefully we'll cover all that for you. So if you're interested, please let the EOD staff be aware. And other than that, we'll see you for the next CPD lockdown lecture, which will be on Thursday night, and same time, same place, 7 p.m. Thanks again for everyone for tuning in, and I will now officially end the meeting.